Good morning, guys, or afternoon, depending on when you're watching this video. We are going to talk about individual module 8, which is under the behavior concept, and we're going to focus on prenatal substance exposure. Here are your learning outcomes. Okay, so let's start. So what is substance abuse? Well, it's the use of chemicals to improve the mental state or induce euphoria. And in pregnancy, there is a specific term we use called a teratogen. And these are any types of chemicals that have the ability or the potential to actually harm the fetus. Several things fall into this category. They can be illicit or they can be illicit drugs. They can be legal medications, over-the-counter things, or prescriptive medications from your doctor. So there are lots of things that can fall into the category of a teratogen. Environmental things. So keep that in mind. So what are some facts? Well, we know that about 225,000 infants born are exposed to some kind of illicit substance while they're still in mom's belly. And this makes it a grave public health concern for the United States. It's best prevented through routine screening and through education. However, this is hard because oftentimes these individuals don't seek prenatal care, so it's difficult to screen them routinely, and it's difficult to educate them because oftentimes they just don't show up. The first trimester use has the most damage to a fetus developmentally. This is when all of the organs, the central nervous system is developing. If you remember back to antepartum when we talked about nutrition, folic acid in the first trimester, even before moms become pregnant, are extremely important because of the development of all those features that a human needs. And drug use during this time frame will greatly hinder that. It's the most frequently missed diagnosis in maternity care, partially because these people don't show up, but also because it's uncomfortable for healthcare workers, including physicians, to actually be honest enough to ask moms about drug use. And it's an uncomfortable conversation to have, so sometimes it's avoided. There's a higher rate of substance abuse in the prenatal period for younger adults. So there's 18 to 24-year-olds specifically. And then American Indians and Alaskan Natives also have a higher incidence. So what are some things that play a role in risk factors for these people? Well, specifically kind of 4 categories: the community they live in, the family they were brought up in or the family they know, individuality, their friends, and school for those adolescents who are at that stage. Specifically in the community, risk factors stem from the availability of drugs in that area, what's accepted in the community, what's normal. Oftentimes communities that have a lower socioeconomic status in general have a higher rate of drug use, and community disorganization in general. And moving on to the family, if your family has a history of substance abuse, pregnant moms are more likely to follow suit. They're more likely to be abusers prior to pregnancy. Families that are in a constant conflict with each other, or their attitudes and their involvement in substance abuse, attitudes having a more positive connotation towards using drugs, and then actually the involvement in doing drugs together. They almost form a bond, kind of the same way with friends. So individuals who are alienated or who tend to be following some sort of rebellious pattern are at a greater risk. Ones who are engaged by their peers or their friends to actually participate in substance abuse. Individuals who have peers that have a favorable outlook on substance abuse are more likely to participate. And those individuals who have an early habit formation. So they form a substance abuse pattern early on in life when they're teenagers. A lot of the times which stem back to the family or the community that they live in. And then things in relation to school that we see, those individuals who have early and persistent antisocial behavior during school, the ones who miss class frequently, who are poor performers, or who have a lack of commitment, those individuals should be looked at closely because they're at a greater risk. So this is not an all-inclusive list, as you can see on the bottom of the PowerPoint, but these are some of the substances that we see in labor and delivery, in the hospital, in the health department setting, just in prenatal care in general, that are abused probably most frequently. Caffeine, alcohol, cocaine and crack, marijuana is a big one, PCP or angel dust, ecstasy, heroin, methadone has become very big now, methadone and heroin both. Methadone because a lot of these women are in a treatment program for some type of opioid dependency. So they're on methadone through some type of program. Heroin because the methadone programs are expensive and oftentimes they can get heroin cheaper and believe they can achieve the same thing they can do with the methadone program. Tobacco use is a really big one. And amphetamines like meth, you're seeing that grow more and more and more. So there are actually 5 Federal Drug Administration classifications for legal substances. And these are important to be aware of as a nurse in this field because it is important for you to know what you're administering to your patient, what category it falls into, and what the potential for harm on the fetus is. So we have 5 categories, and they're split up into letters A, B, C, D, and X, all categorized by the FDA, and they have to do with research studies, which is how these categories have become broken down. So for category A, there have been plenty of studies in women, and there is no shown fetal risk associated with that drug. An example of a category A substance would be something like milk of magnesia. Category B have animal studies that have shown no risk, but there are no studies for pregnant women specifically, and the only studies that have been done in humans show no risks. Most of your drugs fall into the category B section of classifications. So these would be things like your penicillins, Tylenol, Mucinex, Zantac, Benadryl, those types of things that pregnant women can take fairly safely and are usually instructed to take. Many of the over-the-counter drugs that relieve some of those symptoms of pregnancy fall into this category. And then we have category C drugs. And for the category C classification, there have been no adequate studies in animals or humans that are available for physicians to refer to. So animal studies that have been done show teratogenic effects, and there have been no studies done in women that are available. The lack of information on this category is problematic for caregivers because you can't be sure one way or the other. There are several types of drugs that fall into this category. Tums, Sudafed, labetalol, Motrin and aspirin, Prozac is one that falls into this category. And one of the HIV drugs, actually, a fairly popular one, Zidovudine, falls into this category. So what makes this category a problem for caregivers is they have to weigh the risks and the benefits based on what they prescribe or what they educate their patients can take. And then we have category D, and in this category there have been studies that actually show evidence of human fetal risk. So we know that these types of drugs will actually cause some type of damage, or they're at higher risk to cause damage than maybe some other things. The big thing here is that caregivers have to really outweigh the risks before they prescribe these drugs. So in some situations, the benefits of the drug may outweigh the risks of fetal danger in certain situations. Some examples of drugs here would be things like Xanax, Paxil, Klonopin, HCTZ is one. And so you think about your mom who has a severe bipolar disorder and she's taking Paxil. Her physician may find it more beneficial for her to continue on that medication in opposition to discontinuing that medication due to the risk it could pose her fetus, because maybe she was suicidal in the past. And then we have category X drugs. These are definitely the no-no ones. And there are demonstrated fetal risks in this category that clearly outweigh any possible benefits that they could give to the mother. And these would be things like methotrexate, Coumadin. Accutane is one that you might see in adolescents. Accutane has a very high risk for causing fetal anomalies. And here's you a chart that sort of describes these categories. So we're going to talk about some of the substances that are commonly abused during pregnancy in the next following slides. Cocaine. I have these following slides divided up into maternal and newborn findings. And so looking specifically at cocaine, the biggest thing that we think of when we think of cocaine for a woman who's abusing this substance prenatally is placental abruption. Cocaine is most likely to cause this antepartally or intrapartally, and it's something that we look for very carefully if we have a woman who we know is abusing this substance. It can cause fetal demise, cardiovascular effects on the baby and the mom, CNS effects, nasal and sinus diseases if it's snorted. It can be detected in the urine for about 4 to 7 days after use in pregnant women, but typically cocaine is metabolized very quickly, and it will often be gone by 48 hours after use. It does cross into the breast milk and can affect the baby, so we do not allow or recommend moms who are cocaine users to breastfeed their babies after they're born. In newborns, what we see are cerebral infarcts. We see microcephaly in these babies, learning disabilities. They have decreased interactive behavior. They have certain central nervous system anomalies, cardiac and genitourinary anomalies, and they have a greater risk of SIDS. For alcohol abuse, the moms are at a much greater risk for miscarriage for those who use alcohol during pregnancy. Their babies are more likely to be stillborn, and they're more likely to have low birth weight infants, partially because they're malnourished themselves. And that's one sign we see in moms with a history of alcohol abuse, is that they drink instead of eat, so they're malnourished themselves. Sometimes this is a difficult one to actually find or assess, so it's important to pay attention to the really subtle signs for women who are alcohol abusers. A lot of the times it may just be a smell that you get on assessment. Breastfeeding for alcohol abusers is not necessarily contraindicated, or moms who use alcohol. Maybe abuse is not the word for this, but so breastfeeding is not contraindicated, but if the alcohol use is excessive, it can actually intoxicate the infant. And for the mom specifically, it can also interfere with the letdown reflex. Anomalies can occur as early as the first 3 to 8 weeks of pregnancy for fetuses of moms who abuse alcohol. And if you think back to antepartum, this is really a time whenever moms don't even know they're pregnant. A lot of the times mothers won't even discover they're pregnant until 6 to 8 weeks. So if they're drinkers, then potentially their baby has already been affected before they ever even know they're pregnant. And what we see in babies is mental retardation, and actually preventing alcohol abuse or not using alcohol during pregnancy is the most preventable cause of mental retardation in the United States. Microcephaly is another thing we see. Hypotonia, so babies that have little to no tone. These babies have feeding difficulties. Oftentimes they're deaf. They have something called midfacial hypoplasia. We're going to see a couple of pictures of that following this slide. These babies have cardiac anomalies, intrauterine growth retardation. Some of them may have fetal alcohol syndrome and cerebral palsy. And cerebral palsy is a non-progressive impairment of motor function, especially muscle control, coordination, and posture. And so these babies born with cerebral palsy have a greater risk for aspiration in terms of feeding difficulties due to their impairment of motor function and muscle control. So here you see some of the physical signs that you might see on a baby in relation to fetal alcohol syndrome. We've got a small head, which is microcephaly. They have a low nasal bridge and epicanthal folds. Sometimes they have minor ear anomalies. And they've got a really thin upper lip. And so here's what an older child with fetal alcohol syndrome may look like. Again, a small head, a short eyelid opening. They have a flat mid-face, short noses, and again you can see the thin upper lip there. The smooth philtrum, so this place right there above your lip where you kind of have that indentation right above the middle of your upper lip, that's pretty smooth on babies that have fetal alcohol syndrome. Another telltale sign. Moving on to nicotine. This is one you probably will see more often than anything else, are moms who abuse nicotine during pregnancy or who are addicted to nicotine. On the maternal side, we see miscarriage is a huge thing that happens prenatally to moms who abuse nicotine. They have a greater difficulty conceiving, and if they do conceive, then they have miscarriage and oftentimes preterm labor. They're at risk for placental abruption. They're at risk for low birth weight babies, premature aging of the placenta, arterial spasms, and polycythemia in the fetus, which can cause fetal demise. So that's all things we may see on the mom's side. If you think about the placental abruption, the premature aging of the placenta, the arterial spasms, one thing we know about nicotine is that it affects our vessels, right? It disrupts oxygenation, it disrupts the blood flow in the vessels in a way, and can cause these things. For the babies, we see small for gestational age babies, they're at a greater risk for SIDS. And in the school-aged kids, we often find diagnoses of attention deficit hyperactivity disorder. These babies come out usually fairly irritable, they're jittery, and they have an increased risk for respiratory issues like bronchitis or pneumonia. And then even after they go home with mom, you often find them come back in with respiratory issues, partially due to the fact that they're smoked around. So moving on to opioids. Whenever I think of opioids, I think mainly of methadone and heroin. There are certainly other ones, but methadone and heroin tend to be the big ones these days. On the mom side, we see premature birth, low birth weight infants in general for opioids. Fetal narcotic abstinence syndrome, fetal death, respiratory depression, or an increased risk for infection. On the newborn side, we see respiratory distress syndrome, hypoglycemia, intrauterine growth retardation. We see severe symptoms of withdrawal oftentimes with these babies. Meconium aspiration syndrome is another one, which makes sense if you look back over at the maternal side where you see respiratory depression and hypoxia, because we know if moms are deprived of oxygen and are pregnant, then also babies are deprived of oxygen. And we know that meconium prior to delivery is often a sign that a baby has become hypoxic or had some type of hypoxic injury in utero. The neonatal abstinence syndrome is very likely with these babies, and the withdrawal for opioids can last anywhere from 2 to 3 weeks. These babies tend to be very, very sick. They end up in the NICU, oftentimes on medication to help control their withdrawal symptoms. One reason I think of methadone specifically here is because we have a lot of methadone programs in the area, and a lot of moms participate in those methadone programs. And they go in every week and they get a weekly dose of that methadone, even throughout pregnancy. One thing different that we see in terms of newborns for moms who are on methadone is that they tend to not have the lower birth weight infants. Methadone moms tend to have higher birth weight infants, and these babies have a higher risk of SIDS. A specific example I can give you is that I had a family member who actually was in a methadone program for about 6 years, and she got pregnant and continued on her methadone program. She delivered around 34 weeks, so she had a premature birth, but her baby weighed about over 6 pounds, about 6 pounds and 8 ounces, which is pretty big at 34 weeks pregnant. So that's just a specific example of a higher birth weight for a methadone user. On the other hand, heroin users tend to have the more low birth weight infants. Those babies are more small for gestational age. And unlike we see for most babies who go through neonatal abstinence syndrome, heroin babies have decreased reflexes when the majority of babies have increased reflexes. So that's just something to keep in mind in terms of your nursing assessment if you have a mother who's a heroin user as opposed to a mom who has a baby that has been exposed to cocaine. Also with heroin, you may see hypothermia as well as hyperthermia. Just another assessment thing to keep in mind. So what are some red flags that you may see in terms of moms who abuse drugs during pregnancy? Oftentimes, prenatal substance abuse is difficult to detect. And as the nurse, very subtle signs may be your biggest clue to probe more deeply. Usually these moms have a history of vague and unusual frequent medical complaints. They show up to the ER frequently, or they show up to your OB unit frequently with just vague, unusual complaints. And oftentimes there's nothing found with those complaints and they get sent home. So that would be a red flag to you as a nurse. They have a history of addiction or use in the past, or their client or their partner, they as the client, their partner, or their family has a history of addiction or use. They've had previous children that have been removed from their home. That's a red flag. They have high-risk sexual behavior, so they are into prostitution, or they have a history of sexually transmitted infections, or they have a presence of an STI. Maybe they've got a psychiatric illness of some type. They've had childhood or domestic abuse in the past. Those people are more likely to use and abuse substances. Or they are incarcerated or have had a history of incarceration. Here's some more red flags. Physically, what you may see are patients who have appetites that have changed. They have a poorer nutrition than your general patient because they spend their time using whatever is their substance of choice rather than nutritionally taking care of themselves and eating like they should. You may see dilated or constricted pupils, depending on what types of drugs they are using. You may see that their nasal mucosa is inflamed, or they have frequent nosebleeds, so that would be for your cocaine snorters. You may be able to see track marks or abscesses on their arms or their legs. So you think about the meth users and that typical meth face that many people get, all those sores they get on their body. That can also be another physical sign of substance abuse. Slurred speech, they have unsteady gait if they're high when they come in. And you may smell unusual odors. It's very easy to smell nicotine. We all know what that smells like. And then you may smell alcohol in the breath. There are other substances that have certain distinct smells that you may or may not recognize depending on your history and what you have experience with. But there are often many substances that people abuse have no smell. These people may come in with nausea as well, especially if they're withdrawing. Behaviorally, what we see are people who are fairly poor historians. They have a memory lapse for about everything you ask. They have mood swings. They have hallucinations. They have no or late prenatal care or frequently missed appointments. They're depressed. Oftentimes they're agitated when they come in, or if they're not agitated, they may feel extremely good and have that sense of euphoria that they seek by abusing the substance. And sometimes you may see a history of suicidal gestures, or you may have someone who comes in that has attempted suicide. That should be a red flag that you need to assess further for substance abuse. So what should you do as the nurse in terms of assessing from a maternal standpoint? So here is sort of a list of to-dos. Definitely not all inclusive, but these are some main things that would be very important. We have to screen at all stages of pregnancy, so antepartally, intrapartally, and even postpartally. It's very important that we screen and assess these ladies for substance abuse during all of those times, and that's if they are seeking prenatal care. We need to screen the newborn after birth. So oftentimes, like I said, substance abuse during pregnancy is very hard to detect. And so not only do we look at the mom, but if we have missed those subtle signs, then what we may see is that we discover they're substance abusers after they've delivered, only because we have observed those signs in the newborn. We should evaluate for HIV infections. Although here in North Carolina that's a mandatory test, and in fact I think it's mandatory all over the country that prenatally you are screened for HIV. Antepartally, whenever you find out you're pregnant, with your prenatal labs, and then again when you come into the hospital to deliver. It's still important to keep HIV infection in mind for those who abuse substances, because often they have those high-risk sexual behaviors and a history of sexually transmitted infections. We may have to do urine drug screening. If we suspect that there's abuse, we may have to get their urine screened so we know what exactly we're up against in terms of drug-wise, if mom won't tell us. Babies will get meconium drug screening, and they oftentimes get a urine drug screening as well if mom is positive, or if we see signs that we believe may indicate that the baby has been exposed to some type of substance in utero. Urine drug screening is going to show drugs in newborns that have been taken recently, something that's been taken within the past day or so. Meconium drug screening is going to show drugs that have been used. It's going to give you a better history of drugs that have been used, because we know that meconium is stored. Babies drink that amniotic fluid, and that's where this meconium comes from in their GI tract. So makes sense that meconium would show a longer history in terms of drug use as opposed to urine. Another thing that is very important in terms of your nursing assessment is to ask questions. And you have to ask questions in an open-ended and a non-judgmental manner. It's important to ask the less threatening questions first. So there's a thought process and sort of a mind game to this. Ask them about smoking initially, and then move into some of the more hardcore substances. They oftentimes feel much less threatened if you're only asking about smoking, because that doesn't seem as big of a deal. People don't think of nicotine abuse as a substance abuse per se. Also, when you ask those open-ended questions and in a non-judgmental manner, think of examples of ways that you can do this. So, for example, it would be better to say to a mom, how much alcohol do you drink in a day? As opposed to saying, you don't drink alcohol, do you? If you ask a mom, you don't drink alcohol, do you? She's going to say no to you. But if you say to her, how much alcohol do you drink in a day? Then she's more likely to give you a more honest answer. And you've asked her in a way in which she can't just say yes or no. Another important thing to remember in terms of your nursing assessment, just in general, whenever you get any type of patient in, is that almost 1 out of 10 women in the United States are abusing a drug at any given time. So if you think about it in that way, the likelihood that you're talking to a mom who abuses a substance of some kind is pretty high. Some nursing interventions to go along with your assessment in terms of mom. It's very important that your assessment is ongoing for those clients who have been identified as either currently abusing a substance or clients who have been identified as being at risk. If they are seeking prenatal care, it's really important that you follow up and continue that ongoing assessment throughout their prenatal care and then throughout their hospital stay, and then if they have a home nurse, throughout their postpartum stage of pregnancy. Oftentimes we refer these people to counseling or find them a counselor of some kind due to their substance abuse. We might refer them to treatment programs. Sometimes they leave the hospital and go straight into a treatment program. Social services is often involved with these cases. We have to educate moms, specifically prenatally or at preconception counseling, to avoid alcohol. If they're smokers, to line them up with a smoking cessation program. And then we have to have very close monitoring of the mom and the baby during all stages of pregnancy. And then even more once the baby is born, once it goes home, which is why you try to involve social services. Okay, so moving on to your nursing assessment for the newborn, we're going to switch gears and talk more about the newborn here than we are about the mom. Once a baby is born, assessment-wise, it's very important for you to monitor for signs and symptoms of neonatal withdrawal. And there are specific tools that we as healthcare providers use to help us monitor these signs and symptoms. One of them that's used most widely is called the Finnegan tool. And what it helps assess for are all of the different signs and symptoms that you might find for a baby who is withdrawing. Specifically, as nurses, we assess for alterations in the baby's reflexes. Usually those are increased, with the exception of the one that we talked about with opioids. Heroin babies, they typically have a decreased motor reflex, but for the most part, babies who are withdrawing from some type of substance have increased reflexes. We look at their behavior. We look at their physical characteristics to see if they have any sorts of anomalies. And then systemically, specifically, we assess all of the systems because substances can affect them all. So, for example, for your central nervous system, we find babies exposed to substances in utero are typically more irritable. Like I said, those reflexes are increased. They have tremors, and a lot of the some of the times, if their withdrawal is bad enough, they will end up having seizures. Respiratory wise, we find babies that are going through withdrawal have a lot of nasal congestion. They may sneeze excessively. They have frequent yawning. They have tachypnea. So for newborns, we know that's greater than 60 breaths a minute. In terms of their GI tract, you may find these babies actually projectile vomit. It's not like a normal spit up. They actually projectile vomit. They're poor feeders. They oftentimes have diarrhea. Metabolically, what you find is that babies sweat. And if you think back to our newborn lecture where we talked about thermoregulation, babies aren't supposed to sweat. So if you find a baby that's sweating, especially with an increased temp or hyperthermia, that's one of the first things that we think is that they are going through withdrawal from some type of substance, because that's definitely not normal for a newborn. So the neonatal abstinence scoring form, or that Finnegan tool that we just talked about on the previous slide, is part of your newborn nursing assessment if you suspect a baby who you've assessed signs of withdrawal in. And this doesn't only have to, we don't only use this tool just if you assess the signs and catch some of those, but if we have a mom who we know has a positive history of substance abuse during pregnancy, we automatically start this Finnegan tool once the babies are born. And this is a 21-item diagnostic tool, and it monitors the severity of neonatal abstinence syndrome. And along with monitoring the severity of what's going on with the baby, it also helps healthcare workers to monitor the success of whatever treatment that they're giving to a baby who's going through withdrawal. So if you have a baby who's on a phenobarb drip in terms of withdrawal or for withdrawal, this tool will help us assess how well that pharmacotherapy is working. Scoring is done every 4 hours until the baby is deemed stable, and then the tool can be discontinued. However, if the baby scores anything greater than or equal to an 8, we have to bump our assessment time up to every 2 hours. So anything less than 8, we can do every 4 hours until the baby is stable. Anything 8 or greater, we have to do every 2 hours. If we get a score of 8 or greater 3 times in a row, then usually your physician is going to order some type of treatment for withdrawal. And when I say treatment for withdrawal, I mean some kind of medication treatment for withdrawal. The first 96 hours of a newborn's life is pretty telltale. So if we have a score that's less than 8 for the first 96 hours of life, and that should say less than 8, we can discharge those babies, and they don't indicate a need for any type of drug therapy. The higher the score in the Finnegan tool, the more severe the withdrawal is in the newborn. Here's an example of the Finnegan scoring tool. So you can see it's divided up into 3 categories there, and they're all body system assessments. So there you have at the top your central nervous system disturbances. Secondly, you have your metabolic, vasomotor, and respiratory disturbances. And thirdly, you have your GI disturbances. So if you compare this tool with the risk factors that we're getting ready to look for, or the signs of withdrawal that we're getting ready to look for, you're going to find that they pretty much correlate pretty exactly. So here's what you're going to see in a baby who is going through a neonatal abstinence syndrome. Clinically, here is what manifests, and here is what you as the nurse would actually be able to see. These babies are very irritable, sometimes non-consolable. They may have seizures. They have a shrill, high-pitched cry that is excessive and can't be consoled. They have temperature instability, so they have a labile temp. They may be up and down, up and down. They constantly move, jittery, tremors. There's sweating. That's part of that vasomotor instability. They may be mottled. You might find that projectile vomiting. They may not be great feeders, partially because they have poor reflexes in terms of sucking and swallowing. They may have hypertonicity, so that would be your increased reflexes that you find, hyperactive reflexes. These babies may have diarrhea. This excessive sucking and swallowing that you find is persistent and it's uncoordinated. So it's not done in terms of whenever they're hungry and they're ready to feed. They just have this excessive sucking and swallowing all the time. That's persistent and it's uncoordinated. These babies have tachypnea, so they're breathing greater than 60 times a minute. They may have greater periods of apnea than normal newborns, excessive yawning, excessive sneezing, and a disturbed sleep pattern. And oftentimes that disturbed sleep pattern has to do with their irritability, their inconsolability, their temperature instability. Those increased reflexes cause them to sort of jerk and have those tremors. And so oftentimes if they can't quieten and calm themselves, they can't go to sleep. So what can we do for the newborn as nurses? Well, if they have that score of 8 or greater consecutively times 3 on the Finnegan tool, one thing that we may find ourselves initiating is a phenobarbital drip. And mainly we find that with alcohol and opioid withdrawal in newborns. That's what you'll find your healthcare provider will order is phenobarb. And that is to help them avoid seizures. Phenobarb is an anticonvulsant. We have to ongoingly monitor all of those systems through that Finnegan tool. We monitor their eyes and nose because we know they have lots of diarrhea, that projectile vomiting, and they're poor feeders. So it's important to monitor their eyes and nose and their daily weights. Oftentimes we feed them some type of hypercaloric formula. So instead of just a regular caloric formula, we may feed them a 24-calorie formula. They get frequent and small feedings, which makes sense because they have projectile vomiting. They don't digest as well. They have diarrhea. They have those hyperactive reflexes. So if we overfeed these babies, they're more prone to vomit. Plus, they may have nausea from going through withdrawal from the substance that they received while they were in utero. If they have a severe poor sucking and swallowing reflex, then we're going to hold these babies' feedings, and they may end up with an NG tube because we do not want to increase their risk of aspiration by feeding them. If they are able to suck and swallow well enough to feed, then we may have to intervene by trying different types of nipples just to help them sort of coordinate their sucking and help them get the formula out of the bottle better. If mom is positive for HIV, cocaine, PCP, excessive amounts of alcohol or amphetamines, then we do not allow them to breastfeed, because those things pass through the breast milk, and we don't want to increase the risk that baby gets those from mom. We have to pay close attention to these newborns' skin integrity because of their diarrhea and their sweating. So these babies typically are more moist than your other newborns. That vasomotor instability they have causes that sweating, and then diarrhea from the withdrawal from the substance can really play a big role on their skin, especially if they're low birth weight, they are small for gestational age, they are preterm, or they aren't getting enough calories and their nutrition level is not up to par. We all know that those types of issues affect our skin, and so we have to pay close attention to their skin integrity, changing diapers often, changing sheets often, changing clothes often, those types of things. Another thing important nursing intervention wise in terms of maintaining comfort measures is to cluster your care. So we already know that these babies are extremely irritable, that they have difficulty sleeping, and whenever you are caring for them and providing your interventions, try to cluster your care just like you would for any type of med-surg patient. We try to allow them to get as much rest as possible, and not going in every 5 minutes because you forgot to do something the first time. So it's important to be well organized when you're taking care of these newborns. So other ways that we can maintain comfort measures that don't have to do with the administration of drugs is holding these babies, rocking them, loose wrapping, and a pacifier for their excessive uncoordinated sucking. For cocaine withdrawal babies specifically, for some reason they prefer to be rocked in a vertical manner instead of in a horizontal manner. Pacifiers really tend to help these babies, and avoiding eye contact with these newborns seem to help them be more comfortable just due to the irritability that they have. Quiet and low lighting is important to decrease the stimuli that they receive. They're already overstimulated in terms of their central nervous system due to their withdrawal, and so trying to decrease stimulation as much as possible is important. Gentle handling, and this is the only time as a healthcare worker, or I say the only time, this is one of the only times as a healthcare worker that it would be okay for you to lay a newborn in a left lateral position. And the reason for that is to reduce the aspiration risk. They're already at a greater risk for aspiration due to their risk for nausea and vomiting, their poor sucking reflex, their poor swallowing reflex. But should you place these babies in a left lateral position, they have to be monitored continuously for SIDS, and there has to be some extremely good education for the mom, the dad, or the significant other, and the family in terms of why this is being done for these babies. And there has to be a lot of stress put on the fact that this should not be done once this baby goes home. So, what are some nursing diagnoses that we can come up with? I've combined this slide to include both mom and the newborn. So these first 3 bullet points that you see here are specifically diagnoses for mom, and the last 4 are diagnoses for the newborn. So let's take a look at these. For mom, imbalanced nutrition less than body requirements, because she oftentimes, if she's a substance abuser, she's got inadequate food intake because she would rather use her drug than take care of herself nutritionally. Risk for infection, especially if she is an IV drug user or if she has those meth pox, like we talked about earlier. Risk for ineffective health maintenance. These parents oftentimes have a lack of information about how their substance abuse affects the fetus. And I find this typically with your moms who have been in methadone treatment programs. They don't have all of the education that they need in terms of how that methadone treatment program truthfully affects the fetus. So they need a lot of education. And then looking at these ones for these last four for the newborn, we have risk for alteration in comfort related to their withdrawal. We might have that risk for skin breakdown like we just talked about. Ineffective infant feeding pattern related to their excessive and persistent and uncoordinated sucking and swallowing reflexes. And then sleep pattern disturbance, which we talked about, is related due to their irritability, their constant movement. And one way we can help them with that is to swaddle them up or to hold them. So what do we expect as nurses? What do we want our outcomes to be for this patient population? These first four are related to the mom, and we want her to avoid substances in situations that put she and her fetus at risk or in danger. We want her to get regular prenatal care, so we don't want her to miss appointments. We want to take care of her in a non-judgmental way so she feels okay about coming back. We want her to be able to describe the impact of her substance abuse on her and her baby. We want her to give birth to a healthy newborn. Remember, our goal in this course is a healthy mom, healthy baby. The woman agrees to accept a referral to social services or another community resource. So maybe we have found her a referral program or a rehab program to go to after delivery. We want her to accept that referral, and we want her to follow through with it. And then these last three, specifically for the baby, we want the baby to remain safe during withdrawal if the baby experiences that. We want the utmost comfort during the withdrawal period. And we want the baby to feed, sleep, and to gain weight appropriately, all mitigating an unhealthy outcome. So there's a little video on the next slide. And this is a story about drug-dependent infants that are detoxing at a Tennessee neonatal intensive care unit. And we're going to watch this really quickly.
One of the areas that I've been particularly interested in is the area of children.
We intend to be sure that everybody in this room and every child in this state is somebody.
No matter where they're born, no matter to whom they are born,
I want to make sure that every child
has a chance to live up to his or her God-given potential.
I've spent my life fighting for children, and I'm not stopping now.
I'm Hillary Clinton, and I've always approved this message.
A quiet epidemic on the rise where roughly one baby an hour in this country is born hooked on prescription painkillers their mothers are abusing. These innocent victims face an uphill battle, as we saw when we were invited into one special hospital ward in Tennessee. ABC's Juju Chang brings us this tale of hope and heartbreak as part of our division-wide commitment to telling the stories of the invisible among us, a hidden America.
It's noon in the neonatal intensive care unit at East Tennessee Children's Hospital, and baby Grayson, just 48 hours old, is shaking again.
He's tremoring.
Grayson was born with a serious drug dependency because his pregnant mother was addicted to painkillers. Now he gets morphine every 3 hours to cut the pain of withdrawal. Grayson was brought here from a nearby hospital to this special unit for detoxing newborns. Right now, there are 23 tiny patients here going through withdrawal, mostly from prescription pills like OxyContin, Vicodin, or Percocet.
It's like they're inconsolable. I know people probably think I exaggerate when I say they have this very fearful look in their eyes. Well, they do. Good morning.
Carla Saunders is the head nurse of this special unit.
They'll have really bad tremors, really bad jitters, very bad irritability, vomiting, diarrhea, stomach cramping.
Nightline was given rare access for 4 days and nights to witness firsthand what they see as a new and hidden epidemic in this country, striking the most innocent of victims.
When I started, you maybe had a withdrawal baby once in a while, and then it was once a month, and we got 6 this weekend, all at one time. It's gone from a drip to a flood. A flood. It is a flood.
After 2 days of waiting, there's finally room on the ward for Grayson.
Now we're transporting this baby to the 3rd floor.
He's fairly jittery because he needed a lot of Tylenol.
We give it to him twice today because he's been around borderline.
It's starting to look like they may begin weaning him off the morphine.
If it's 2-year-old, then they start weaning rough.
Ashton, just 19 years old, is Grayson's mom.
He's done so good today.
Good.
He's just so, happy.
Big difference from 2 days ago?
Yeah. Mama needed to be more awake.
She says she tried the prescription painkiller roxicodone for the first time as a party drug while still in high school.
How easy was it for you to score painkillers?
They're pretty much easy to find if you want them.
It's everywhere.
It is crazy to see how many kids are strung out on opiates.
Ashton says she lost a basketball scholarship to the drugs. Having tried to go cold turkey on her own, she knows just how painful withdrawal can be.
You get cold chills, your skin feels like it's crawling, like it's crawling, literally. I mean, you just feel so, you don't want nobody to touch you.
Knowing how awful it feels, what goes through your mind when you know that Grayson's going through that now?
It drives me crazy. I mean, it literally makes me, honestly, it makes me beat myself up every day.
Ashton was trying to recover and on methadone when she got pregnant, but doctors advise pregnant mothers not to stop using because the baby in their womb might suffer from potentially lethal withdrawal. It's clear why when you see Grayson now. Nurse Saunders is helping develop a treatment program using a powerful combination of drugs, trial and error, and lots of TLC. It can take weeks, even months, for these tiny bodies to withdraw from what their mothers were hooked on.
How is Grayson doing? Still having the jerk and tremors, and he's got the loose stool.
After days of progress, baby Grayson suffers a setback. On our 4th day on the unit, Saunders still can't wean him off the morphine as she'd hoped.
Not only is Grayson not going to wean tomorrow, I'm going to go right for an increase for him.
Now Nurse Saunders has to break the news to Ashton.
Grayson, this morning was starting to get a little more jittery, and he's kind of progressed through the day today, and so we've had to go up on his medications. I think you can see him twitching pretty good, and
So he's gone crazy overnight, pretty much. It's like it's just went downhill.
This is just probably the first dip in the roller coaster ride.
Okay, buddy, here you go. And this is the increased dose, but this will help settle his jerks down. Wake up! Wake up! Open your eyes! You are so big!
And yet inside the NICU, there are glimmers of hope. After 88 days here, baby Mason is about to go home, a moment that's bittersweet for the staff.
Oh, you wanted me on this conversation. I know you did.
Tell them. You want to tell them about it? It's okay.
What goes through your mind when you hand over a baby that you've taken 3 months of your life to nurture and care for?
It's never easy to say goodbye to them because we do get attached, but we know that we have given them their best shot at the first few days or weeks or months of their life.
3-week-old Grayson is one of the lucky ones. His mother says she's trying to keep clean, taking doctor-prescribed methadone to wean herself from an addiction to painkillers.
Your eyes look a little dilated to me. Are you still using?
I'm still on methadone now, yeah. I have been since I had been, yeah.
But are you using other stuff outside of that?
Oh, no. No. Methadone's the only thing I've used since I got in the clinic.
How do you make it up to him from here on out? How do you prove that you deserve to take him home?
You have to start just detoxing yourself. You have to start doing it just like he's doing it.
If Grayson could understand what you said to him right now, what would you say to him?
Mom, I'm sorry. It's just hard. I mean, none of it was planned, you know? I wanted something better for him because, I mean, I grew up around it, I know. And it wasn't fun. I didn't want that for him. I wanted better for him because I wanted to be the mom that I didn't have.
For Nightline, I'm Juju Chang in Knoxville, Tennessee.
As of tonight, baby Grayson is still in the hospital but could be sent home in a week. In some states, abusing painkillers during pregnancy is considered child abuse and is illegal. But in Tennessee, mother and child will be allowed to stay together as long as Ashton is in treatment. Our thanks to Juju.
So there you see an actual real-life example of what signs and symptoms that you may see in terms of a baby who's going through withdrawal and who has that neonatal abstinence syndrome. You notice the baby Grayson had those excessive reflexes, the high-pitched cry. You can notice his tremors greatly. And you see he was on methadone for his withdrawals. So there are different drugs that you can use. Very sad and heartbreaking. So important as a nurse in this field to be able to recognize this prenatally in mom so you can get her as much help as you can before the baby is born. So they don't have to go through that. And that is the end of your individual module 8 on behavior, specifically focusing on prenatal substance exposure.